Today we are breaking down traumatic brain injury, or TBI, a high-priority topic the NCLEX loves to test through prioritization and safety questions. Your primary role and where the exam will focus is on preventing secondary brain injury. The primary injury, which is the initial impact from the accident or fall, is over. The test questions will center on your ability to prevent the subsequent damage caused by issues like hypoxia, hypotension, and especially increased intracranial pressure. The Glasgow Coma Scale, or GCS, is a critical assessment tool you must understand functionally, not just academically. The exam will not simply ask you to calculate a score. Instead, it will present a clinical scenario describing a patient's responses and expect you to know what to do. For example, if a patient opens their eyes only to a painful stimulus, makes incomprehensible sounds, and withdraws from a painful stimulus, you need to recognize this as a GCS score of 7. The number itself is less important than its meaning, which is a severe brain injury. A GCS of 8 or less is a classic indicator for preparing for intubation. The most common exam trap involving the GCS is a subtle change. A patient whose GCS drops from 14 to 12 is experiencing a significant neurological decline, and this requires immediate notification of the healthcare provider. This leads directly into recognizing and managing increased intracranial pressure, or ICP. The NCLEX will absolutely test your ability to spot the earliest signs. Do not get distracted by dramatic, late-stage symptoms. The very first and most sensitive indicator of rising ICP is a change in the level of consciousness. This can manifest as new onset restlessness, irritability, or confusion. In a prioritization question where you have 4 TBI patients, you must assess the patient who has become newly agitated before the patient who already has a fixed and dilated pupil. That blown pupil is a catastrophic sign of brain herniation, but you might have prevented it by acting on the earlier, more subtle change in consciousness. The classic late signs of dangerously high ICP are known as Cushing's Triad, and you must have this memorized. It includes bradycardia with a full bounding pulse, hypertension with a widening pulse pressure, and irregular respirations. A simple way to remember this is to imagine the brain is being crushed. As pressure builds, the heart rate goes down due to pressure on the brainstem. The blood pressure goes way up as the body desperately tries to perfuse the compressed brain, and the breathing gets weird as the respiratory center is compromised. Seeing this triad means brain herniation is imminent. Expect select all that apply. Questions focused on nursing interventions to control ICP. The core principles are promoting venous drainage from the brain and reducing its metabolic demands. Correct actions include maintaining the head of the bed at 30 degrees and keeping the patient's head in a neutral, midline position. You must avoid neck flexion or rotation, as this can compress the jugular veins. You will also manage fever aggressively with antipyretics and cooling blankets. As fever increases the brain's metabolic rate and oxygen consumption, preventing the Valsalva maneuver is also key, so you'll administer stool softeners to avoid straining. Finally, watch for common exam traps related to TBI management. Suctioning is a frequent one. While it can be necessary, suctioning raises ICP. Therefore, it must be done for no longer than 10 seconds at a time, and the patient must be hyperoxygenated before and after each pass. Another major trap is fluid management. Hypotonic fluids, such as D5W, are strictly contraindicated because they would shift fluid into the brain cells and worsen cerebral edema. The standard of care is to use isotonic solutions like normal saline.